All right, I am Trevor Van Schooneveld. I'm going to talk about action. So Scott set me up very well. I appreciated it. We are going to go through, these are my disclosures. They're mostly related to C. diff. I'm going to talk briefly about Procalcitonin, very briefly, and I have talked on that before. These are my objectives, that we just identify some strategies and talk about things to help them be successful. But this is really my goal, that you can have a variety of stuff that you could do at your facility and have some idea of how to go about doing it. Because we, as part of ASAP, have gone out to a lot of hospitals, and a lot of the questions we get are, well, we have the checklist, we've looked through the core elements, so what should we actually do? How do we sort of decide what to do, and how do we implement that, and what tools are out there? And so I'm just going to talk about a host of things. I'm going to give you a whole bunch of opportunities. But before I do that, I want to survey the audience. How many of you here are physicians? So we have some. Good. How about pharmacists? Lots of pharmacists. How about nurses? If you're a nurse, great. All right. So everybody in this room, do we have any other lab people? Good. Lab people. Every single person here is an important part of the stewardship team. And that's one thing that I've really found going around doing this at our facility is that stewardship team, and the reason the CDC has all those parts of it in the core elements is that the group is really important. So you may have formed a stewardship committee, and you say, well, we have a committee, that's part of the core elements, right? You have some people, and you say, well, so what are we're supposed to improve antibiotics, right? So right. So what do we do? I don't know. We've got, what? I don't know what to do. So how do you decide what to do? The CDC has set you up, if you followed their guidance, I think, for success. Because first they've said you have to have leadership commitment. And leadership commitment means usually you have people who are engaged. And hopefully you have some resources. That's usually what leadership commitment means. And that leadership commitment is going to build the team. And then the team is going to do the other things that Scott talked about, action, tracking, reporting, and education. And so your team is going to say, well, what should we do? And your team will usually have some sense of what are the problems. And they'll say, well, I think this is a problem. I think we treat too much asymptomatic bacteria. Oh, I think we use too much vanco. But, you can say that, but the question is always, is that really a problem? And that's where getting data is very important. And again, that's where the core elements come in, where they talk about tracking and reporting. That's data. What sort of data might you use? You might use antibiotic use data. Do we use too much vanco? Well, we should probably look and see how much vanco we use. Do we have a resistance problem? What about clinical outcomes? Are our patients staying longer than they should when they get C. diff? And then you're going to use that data with your team's expertise to decide, hey, this is an issue, this is a big issue, or yeah, this is an issue, but it's like one patient every 6 months, so it's probably not worth our effort at this time. And then you're going to take your team and you're going to develop a plan about what we're going to do, and I'm going to give you a lot of options. And then once you do that, you're going to do your action, that's your reporting, your education. That's how you do stewardship, okay? So I want to talk a little bit about quality improvement. And who is on a quality improvement committee? All right, a bunch of the nurses, I'm guessing, and if some of the pharmacists. So if you've done quality, and I'm not a quality improvement I don't have any black belts, but I'm just going to lay out a couple of the models because I think they're helpful to think about how do we actually improve quality in our hospitals. And that's really what stewardship is. It's improving the quality of care in our hospitals. This is the PDSA cycle, Plan, Do, Study, Act. I've always thought, what, plan, do? I would think you plan, study, do, I don't know. I didn't design it, but I think it's a useful model. The way you do it is you plan. You get a team together. You figure out what do we need to change? What is the current process that's happening that needs to get fixed? How are we going to fix that? And then how are we actually going to measure that we actually did something good? And I would just emphasize that measure improvement. I have failed many times to actually capture and measure our improvement as a steward. I've just sort of done and not measured. I would encourage you, when you're developing a plan, think about how you're going to measure. Because one, if you're in academics, it'll be helpful. Two, it's going to be helpful to your quality people. Three, it's going to be helpful to you because you're going to say, look at all the great work that I've done. And you're going to be able to show your C-suite, your leaders, say, hey, look at all this great stuff we're doing for patients. We really are beneficial. Yes, we really do need more resources. We could do so much better stuff. Then you're going to do it. You're going to initiate a change. If it's a big change, maybe you want to pilot it, and you're going to measure the results, followed by studying that data and saying, hey, did this work? Did it not work? what didn't work. If it didn't work, then I'm going to act to implement something different. So that's a PDSA cycle. You can go to like day-long, multi-day long things on how to do this. You got it in 2 minutes. The other way is the DMAIC cycle, which this is, oh, I knew I was going to forget this. Define, measure, analyze, intervene, control. I think, right? If any of you are black belts, please don't karate chop me for doing it wrong. So you're going to define the problem, right? What's the problem? What's the issue? Oh, vancomycin. Oh, wrong C. diff treatment. You're going to get a team of experts together. Then you're going to measure. You want to document the process. You're going to collect some baseline data. This is a little more on the front end. The PDSA is a very rapid sort of cycle. We're going to do something pretty quickly. This sort of has a lot more analyzation. This is where you build all these process maps and you do diagrams, and then you're going to analyze all that and try and figure out the root cause. Because the question is always, why are we doing that? And I think if you don't know the why, it's going to be hard to put the intervention in place and have it be effective. Then you're going to do your intervention, you're going to implement it, and you're going to control. Control means I'm going to try and put something in place so that I don't have to like keep doing it over and over again. Some general suggestions for success. So first, multiple sources for input. One person acting on their own to do stewardship is, well, sadly not going to be very effective. Multiple sources not only improve the quality of the intervention, but they improve the acceptability of the intervention, right? If you have your surgeons giving input on your surgical prophylaxis, it's much more likely that the surgeons will actually do it than if I just go to them and say, here's what we're doing to surgical prophylaxis. They'll just laugh at me. Well, they probably won't laugh. They'll be very kind and say thanks. But not do it. Garner support from your C-suite, right? If the leadership says this is a priority, you can usually make things happen. If the leadership doesn't prioritize what you're doing, that's why prioritization, that's why that C-suite priority is so important at the beginning. Then pick low-hanging fruit. Don't go after something that's really hard first. Pick an easy win. If you're going to do something with stewardship, do something you can get accomplished and measure and you know you can do well. Do that first. Build on that success. Say, hey, look, we did this with our limited resources. We'll do more with more resources next time. Also, don't reinvent the wheel. Look at what other people have done. There's a reason we have an ASAP website. That's a reason that Nebraska Medicine has a stewardship website. We have all those tools out there. There's all kinds of stuff in the literature that people have done to improve care. And so just take their stuff. You're welcome to use our stuff. Just make sure and mention that you got it from us. That's all we ask. But take our stuff, use it. That's why we put it there. And then the last thing to think about, and this has been mentioned before, is think about unintended consequences. So we're going to decrease hospital onset C. diff by empowering our nurses to order C. diff tests on anybody who has diarrhea in the first 3 days of hospitalization. Well, that will decrease your hospital onset C. diff. But it may find, as we've learned, a whole bunch of colonized people that maybe I shouldn't have treated in the first place. Right? And so there's trade-offs. And so you just have to think about those when you implement it. And then the last thing, and Scott mentioned this, is engage IT early. This is often an area where people often don't have the resources. But we all, almost all of us, operate now in electronic medical records, right? And that's where people do clinical care. Our residents just spend their time clickety, 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 right? That's the complaint. If you go talk to physicians, what's the complaint? I spend all my time in the electronic record. Pharmacists, you guys spend all your time verifying medicines, putting everything into the electronic record. So we should make sure we use that to our advantage with clinical decision support, with measuring things that we're doing as much as we can. And so when you're thinking about our stewardship team, you really want to emphasize, listen, we need data, we need IT help. All right, so let's talk about identifying the problem. I'll just give you an example from our facility. So this is a theoretical or not so theoretical conversation I may have had with a resident or a fellow on service. I said, well, we seem to use a lot of vancomycin, and our fellows are here, and they probably heard me say this. We seem to use it for everything. I mean, even our orthopedists are starting vancomycin. Do you think that's really needed? You know, I'm like, well, you know, everybody's worried about sepsis, right? They might die because they have sepsis. Plus, it covers everything. So what is the big deal, Dr. Van? Well, haven't you seen the papers on increased renal failure when you use vanc and piptazo together? Oh, yeah, we've seen those. I guess we'll just use ceftriaxone in place of piptazo. Well, that doesn't seem ideal. Those are associated with increased risk of C. diff and ESBL and CRE, so maybe we should do an alternative. Well, I guess we could use Dapto or linezolid, right? Right? And so we just find ways around it. And so this is an example of something we sort of have tried to work on. And so the first thing we want to know is, well, do we use a lot of vancomycin? And the answer was, and I already knew the answer to this, but I wanted the data. Yeah, we do. So these are like our number 2 and number 3 antibiotics we use in the hospital. We use over 100 days of therapy per 1,000 patient days. It hasn't really changed that much. Maybe vanco's gone down a little bit, but you can see piptazo dropped a lot. That was because of the shortage. How about the combination? So we did some quick work in our electronic record and showed that we think 2,363 people got both drugs for at least 1 dose of each within 24 hours in 2017. Is that a lot? I don't know. It seems like a lot to me. I don't know. And then we looked at duration, and we thought about how we can measure success. We looked at how long are people on the combination. And again, we used our electronic record to generate some data that showed over a quarter of people got more than 3 days of the combination therapy. Now, I could say, you have necrotizing fasciitis, you started vancomycin, I'm okay with that. But, by day 3, you probably know what the culture shows, and you probably don't need vancomycin anymore. And so that's another opportunity. And so what do we measure for success? Well, we can look at who received both agents, just how many people, how long did they get it, and then look at some of those antibiotics, both days of therapy for vancomycin, and then some of the antibiotics that people might use in place, because we want to look for unintended consequences. And so then we asked our stewardship committee and some other people, well, why do people use lots of vancomycin? And they said, well, it's broad spectrum, it covers everything, Dr. Van. And boy, it's in a bunch of the guidelines he made for us on our institution website. And I said, yeah, you're right. Oh, sad. We have a sepsis initiative that's like you got to give broad spectrum antibiotics, and you're a bad doctor if you don't give them as soon as a person walks into the ER door. And so that's another incentive. The ED, the team said, well, the ED starts them, and we just kind of keep them going because they started, and it's fine with us. People have sort of this misperception of how prevalent resistant pathogens are, or what bacteria cause in certain infections. Really don't need zosyn for cellulitis. Gram-negatives and anaerobes don't cause it. And then we don't specifically look at vancomycin alone for stewardship. It doesn't sort of meet our criteria right now for what we look at. And so our approach to improving that is to say, well, we'll review all our guidelines and get rid of vancomycin where we think it's appropriate and leave it where we think it is. We're going to educate on the prevalence of Pseudomonas and MRSA, which are pretty stinking uncommon, frankly, in most conditions. We're going to distribute that education in a bunch of venues. We're going to add vancomycin as something we're reviewing as part of our stewardship activities. And then we're going to do some things in our electronic record to try and help this as well. So our team-based pharmacists have added this to their daily workflow where they're going to look at this so that, if we don't catch it, maybe they'll catch it. And then we're working with our ED physicians because the way they order antibiotics is they just have a big menu of every antibiotic they might like, and they just are like that. And so we're going to try and build some clinical decision support into that says, hey, they have pneumonia, you should pick this and this, or this and this, or you have pyelonephritis, why don't you pick that? And so we're going to work on developing that. So it's a work in progress. I don't have results to show you, but I just wanted to show you how you can think through this problem, get the data, plan the data to measure, develop the interventions. And I didn't have to get a big grant to do this. We just kind of put this together because we needed to. Okay? All right. I'm going to skip that. So Dr. Berkman already went through the core elements. I'm not going to go through the core elements. What I'll tell you is when I started doing stewardship, we had one guideline, which had some great stuff in it, but there's a bevy of resources out there right now. There's a ton of options, a ton of things you can do, lots of help out there of things you can do. I just want to mention, so this is from the IDSA SHE guidelines. They have a variety of strategies. If you do stewardship, hopefully you've looked at this guideline. If you haven't, I would encourage you to. And I'm going to talk about a bunch of these strategies, so I'm not going to go through them. They break them up into some general interventions, things that are front end like restriction, pre-authorization, or back end like audit feedback, syndrome focus, clinical decision support, education, which is really important and I'm not going to talk about, but you have to do it all the time because people turn over. C. diff antibiotics, we've already talked about. Some pharmacy-specific things, particularly like PK monitoring, alternate dosing of beta-lactams, which I'm not going to talk about, using extended infusions, IVDPO conversion, allergies, duration of therapy. They have some very specific things about microbiology, which you kind of already heard about. I'm not going to talk much about these other than to mention some stuff on rapid blood culture techniques and procalcitonin, how we can make use of it. And then special populations. If you have special populations, you can work on these. If you don't have special populations, if you don't have a NICU, you don't have to worry about NICU stewardship. But if you do, you really should worry about it because there's a lot of antibiotic misuse. All right, so Dr. Bergman laid this out. There's some different ways to do this. You can develop policies is one way you can do stewardship. You can say, we're going to put a policy in place that says, thou shalt have a dose duration indication. Or you can put together facility-specific treatment recommendations or formulary restrictions. You can do some broad things like create an antibiogram that's sort of broadly applicable. And then, like Dr. Bergman mentioned, focusing on the common syndromes is what's best for critical access. This is really for critical access. I think for larger hospitals, the whole menu is open. But a lot of people in Nebraska operate in smaller hospitals. And so as ASAP, we've gone to a lot of these hospitals and sort of worked with them to see, I mean, it's UTI, CAP, and SSTI. That's most of what's going on. Pharmacists have a very important role. There's lots of things pharmacists alone can do, whether it's IV to PO, renal dose adjustment, redundant therapy, looking at drug-drug interactions, reading culture results. And then nurses, again, particularly in smaller hospitals, I think are really, really important. And we've seen a lot of nurses do a lot of fantastic work in smaller hospitals where they're engaged in the quality apparatus, the infection preventionists. You know, nurses are the ones, like we talked about, that make sure we get cultures right. They can review the culture results with the physician. They're usually, those results are coming back to the nursing units, and the physicians aren't there, right? They're off in clinic doing their thing. Unless you're operating under a hospitalist model, which not that many places are. They can inform the pharmacist or physician when somebody's taking oral, and you know, we can switch to oral because they're on a diet and they're taking their pills, and boy, they seem to be doing really good, and that vomiting isn't there anymore, so why don't we switch? They can educate patients, and then I'll talk a little bit about antibiotic timeouts. I think this is another area nurses can be helpful. All right, so I just want to review some of these strategies and the data to support their use. So restrictions, this is pretty simple. Sorry, you can't have it. Most programs, at least in large hospitals, use this. You know, there's different ways to do restrictions. You say, well, there's a bunch of carbapenem, but we just have meropenem. So you want imipenem? Too bad. We don't have it. Call somebody else. Or you can say, hey, Dapto, if you're not an ID doc, you're not using Dapto. Or we'll give you Vanco, but if your culture doesn't show MRSA at 72 hours, your Vanco is done. And so there's different ways to do restrictions. The advantage of restrictions is it doesn't take a lot of work. You put it in place, it happens. And it will change use. The problem is it's kind of restrictive, right? Maybe you really do need imipenem. Maybe that Vanco shouldn't be stopped. And then we have this squeezing the balloon phenomena where if all we do is give Zosyn to everybody, eventually people become resistant to Zosyn. Now, they may not be resistant to cefepime or meropenem, but eventually we're going to lose whatever we're using a lot of. Pre-authorization. The way pre-authorization works is I want a drug, I got to call somebody, and they tell me yes or no, depending on what I tell them, if they meet the specific criteria. So, for example, if you want Piptazo, you have to call the ID fellow, or you have to call the pharmacist. The advantage of this, it is very targeted. You pick your drugs, you pick what you want to do. It is effective. It will change use. You can give feedback and say, well, Zosyn for cellulitis, why don't you use Ansep? That might be a better choice. And then hopefully they don't call you with Zosyn again. The disadvantage is it's very painful for everyone. The people making the call, very painful for them. They got to call somebody. The people taking the call, painful for them. They got to be on call. They got to argue with people about whether they should or shouldn't get Zosyn. You know, info reliability, if you look at this, a good portion of the data that people are told is incorrect, not because people are lying, but just because there's a lot of handoffs and, you know, the resident calls and says, well, my supervisor told me to call and get Zosyn on this person, and they don't actually know anything about the person other than they're supposed to get Zosyn. And then, you know, you can't usually do this 24/7, and so if it ends at 8 o'clock, all your surgeons may order Zosyn at 8:01, right? And so it works, but it has some pain. I think the other disadvantage, and this is just a personal opinion, I think it sets up a little bit of an adversarial relationship in that as a stewardship team, I'm no longer your helper, I'm the cop. I'm the one who's stopping you from getting the drugs that you want to use to treat your patient. It's a philosophical thing. I know there are programs in the country that restrict 95% of the antibiotics. Like you can use ampicillin for 3 days, and that's it. And maybe Keflex, and everything else is restricted. So we don't do that because I don't want to endure that agony. So audit and feedback. So those were focused on the front end of starting antibiotics. Audit and feedback is focused more on the back end. Antibiotics have been started, somebody reviews the antibiotics, calls up and says, hey, here's some advice on what we would suggest. So to do this, though, you have to have a process for actually identifying patients on antibiotics or on the antibiotics you want to identify. When we started doing stewardship, we couldn't actually do that, short of looking at, is Mr. X on antibiotics? No. Is Mr. Y? No. Is Mr. Z? Oh, yeah, he's on Zosyn. Let's look at him. And so we actually had to get a third-party software vendor to even do this. Our new electronic record is actually able to do it, fortunately. And then you have to have somebody who's going to actually do that reviewing. And so depending on what you do, you may need, it's going to be somebody who's going to have some time, but they probably should have some expertise as well. It is very customizable. It's very educational. It doesn't delay therapy. The disadvantage is usually the recommendations are optional. People don't have to do what you say. Usually they do, but they don't have to. And it is time intensive for the person doing the reviews. All right, so does it work? This is the data on restriction. In the crosshatch bar is carbapenem use at restricted centers. In the open bars is carbapenem use at non-restricted centers. The dotted line is carbapenem resistance in Pseudomonas at restricted centers. The solid line is carbapenem resistance in non-restricted centers. So you can see less use, less resistance. It works. This is a study that looked at the stewardship team doing pre-authorization. And by doing pre-authorization, they were able to improve the appropriateness of therapy and guideline compliance. Now, they compared this actually to their ID fellows doing sort of a modified pre-authorization. I don't know if their ID fellows were, yeah. My boss, Dr. Rupp, always said his mantra with pre-authorization was say yes to drugs, which maybe is not ideal. That's part of why we don't do pre-authorization, because the people who are doing it just get, anyway. There are a number of programs in the country who have abandoned a lot of their pre-authorization strategies just because it wears out their pharmacists. If you want to know about the pain of pre-authorization, you can talk to our stewardship pharmacist, Phil Chung, over there. So it was his pain in New York when he was there. But the thing I would point out is not only did they improve guideline compliance, they improved clinical outcomes by doing this. Simply having the stewardship team give feedback when somebody was starting an antibiotic improved clinical outcomes. Audit and feedback, does it work? Well, the question with audit and feedback is when you stop antibiotics, do you kill a bunch of people, right? Why do the ICU docs not like to stop antibiotics? Well, because people are sick and they might die. And so in this study, what they did is on day 3 and 10 of broad-spectrum therapy, they had an ID pharmacist give some feedback. They decreased antibiotics use, and a bunch of people didn't die. Second study, where they gave some feedback, they randomized patients to usual care audit and feedback. They had 90% roughly acceptance rate. They had no difference in mortality, but oh, by the way, they had hospital stays that were about 3.5 days shorter and decreased antibiotic and lab costs as well. And so just looking at patients, giving feedback can really improve. And I'll tell you, having done a ton of audit and feedback, we make interventions that aren't necessarily therapeutic sometimes. We'll call people up and say, boy, you know, you should really get an MRI of the spine. They might have spinal osteo. Or that test that we would do this test. Or you should repeat the blood cultures. And there's all kinds of other interventions that you can do with audit and feedback. It's similar with pre-authorization, because whenever you're hearing about the patient case, you can give some expert advice on that case. All right, how do you choose? Well, there's lots of ways to choose for all those strategies. You could pick high cost, you could pick broad spectrum, you could pick high use, you could pick high risk, you could pick novel, which is usually the same as expensive. You could choose by site of infection, you could go by MRSA stuff, you could do double coverage. There's lots of ways to sort of do this. Just a menu of options, and you want to pick that based on, what's your problem at your facility and what do you want to intervene on. For example, we have for many years reviewed treating candida and respiratory tract cultures. And the first few years we did audit and feedback, I used to call somebody every, a couple times a week. I can't think of the last time we called somebody about that. We just don't have to anymore. So maybe we should, I look at the list and it's just not there hardly though. And so people have learned over time, hey, we don't treat candida and sputum because it's monoflora. All right, let's talk about timeout. When am I supposed to be done? Can you remind me, Scott? 2:30. 2:30? Okay, good. We are right on track. All right, so timeouts. If you look at the CDC, Joint Commission, everybody's very enthused about timeouts. And so there's kind of 2 ways to do timeout, right? They're stealing from the surgeons. The surgeons do their timeout. Are we cutting on the right leg? And, are we giving the antibiotics? And is this the right patient? You know, an antibiotic timeout, you can sort of pick 2 times. One, we should do a timeout when we start and make sure we've gotten the cultures and we got the dose and the duration and the indication put in. But what's really pushed is doing this timeout when we're at day 2 to 3. That culture data comes back, timeout, let's review the antibiotics, the culture data, let's decide what to do. Should we stop? Should we change? You know, is this really an infection? So I want to talk about indication duration first before I talk more about timeout. So why include an indication? That's been mentioned a few times. I'll tell you, the reasons I think are, one, because we want people to think about why they're starting the antibiotic. And that the answer is not the patient is sick, that's not an infection. It's not leukocytosis, that's a sign, right? Or a lab finding, that's not an infection. It's not a fever, right? And so we want people to think about, well, what am I treating? The second is communication. Lots of us operate in hospitalist-driven systems where the person caring for the patient now will be a different person in 12 hours, will be a different person in 12 hours, will be a different person in 12 hours, and by 4 days we'll have 7 different people caring for the patient. And if you've ever read a medical note, you may have found they aren't super helpful in finding out why antibiotics were started. Patient on ciprofloxacin improving. What's improving? UTI? Cellulitis? I don't know. What's improving? So the other thing is it allows us as stewardship people to analyze use patterns. How you do this depends on what you have. If you have electronic record, I think computerized, making people put it in is the way to do it. You can do it using forms. You want to think about what level of detail do I want to choose? Do I want 800 indications? Or do I want like 5? Or do I want sort of a menu? Do I want to do it different for different drugs? And then the other thing is, do you want to have fever, sepsis, those vague things that everybody will have sepsis, right? Okay, duration. Why do duration? I think, again, it's to prompt that consideration. Why? How long should I treat this? Plus, when you couple it with indication data, if somebody's reviewing that, you can say, wow, community-acquired pneumonia, they ordered 14 days of antibiotics. That doesn't go, right? It should be 5 to 7. We can have a discussion about that. How do you implement duration? Lots of options. You can do pre-specified. If you say it's CAP, you get 7 days. If you say it's endocarditis, you get 6 weeks. Ordering physician specified, we don't set a duration, but we just make the physician pick one. You can say everybody gets 7 days no matter what. Everything expires at 7 days. You could say everything is going to be, as physician ordered, except for Vanco, which stops early. This is how we've done it. We use Epic. We had them build it, so when we went to Epic, we just said this is how Epic comes. Okay? Sorry, this is how it comes. We're not the bad guys. Which wasn't actually true. We were only the second facility to ever do this in Epic. We copied this from UCSF. And so we have a variety of indications. And, we have bacteremia, fungemia, because it is actually an indication, which gets picked a lot. But, we don't have fever. We don't have sepsis. We do have another, but you have to put something in. And then you have to put a duration. If you don't put a duration and you don't put an indication, you will not be signing that order. Okay? It's just the way our system works. So, and people don't argue about it because that's how it is. We've tried to make this easy where if you're using like our community-acquired pneumonia order set, it already says community-acquired pneumonia in 7 days. And so we tried to make it simple for people so to save them work. My theory, I'm not going to talk a lot about clinical decision support, but my approach to using electronic records is make the right thing easy and the wrong thing not impossible, because occasionally in medicine we have to do kind of weird stuff, but really hard. Okay? Impossible is something that particularly our people who do IT don't like, because if something's impossible, that means you have to do workarounds when occasionally you really have to do things that you shouldn't do. Which occasionally, I'm kind of getting this, okay. So, is that data accurate? This is data from Maryland where they looked at almost 400 orders for antibiotics at the time of the order, and then at 40 to 72 hours. What you can see is 90% accurate at the time of order. And so people aren't lying on this. They're generally being accurate. Later on, we get more data, and so we may have more data and, have revised our diagnosis, but it's pretty good data. All right, timeouts. So CDC and Joint Commission both advocates for timeouts. If you do a literature search on timeouts, you will find very little data on timeouts to demonstrate either their impact or how to make them effective. They inherently make sense, right? Makes sense. We should reevaluate the patient. The one study that I'm aware of, other than a checklist study that was done in the ICU that involved a whole bunch of stuff, was a single center, 2 internal medicine wards where they had a checklist where an internal medicine resident twice a week reviewed 4 drugs, carbapenems, moxie, piptazo, and vancomycin. They made antibiotic adjustments 12% of the time when he did audits, mostly changing dose and duration on the initial audit, but they were able to decrease moxie and carbapenem and save, made some significant drug costs because the drugs are very expensive. So it took only about half an hour a day for that resident to do it, and so pretty easy. That's the advantage of timeouts. About anybody can do an antibiotic timeout. So we actually did a timeout study. We did it with our team-based pharmacists. We randomized 3 teams, 3 medicine teams to doing a timeout and left 3 doing their usual stuff. We gave our pharmacists some training on timeout, like, you should sort out what kind of antibiotics. Is it prophylactic versus definitive versus empiric? And then answer some key questions like, is there cultures? What's the spectrum of the antibiotic? What drug are they on? What's the duration? And just try and look at those as part of the pharmacist's workflow, because usually they're looking at that stuff anyway as part of their workflow. And then have a discussion on rounds. And that was the timeout. We said you don't need to stand up and blow a whistle. Just initiate a discussion on rounds and say, hey, I've noticed they're on this antibiotic. Could we switch it to oral? What duration do you think we should have? If that needs to be addressed. If nothing needs to be addressed, don't address it. And so what we found is we're about 55% compliant on the initial timeout and 43% on the subsequent timeout. We picked initial was at 40 to 72 hours. Subsequent was about 48 hours after that, so kind of when you're thinking somebody's going to go home. We also had them doing timeouts right after the person came out of the ICU because that's a time when people are frequently adjusting antibiotics. A lot of people on the late timeout didn't even need a timeout because, ID was seeing them, they were already off antibiotics, they'd already gone home. Unfortunately, we didn't see a big difference in antibiotic change. The only thing we saw was less IV levofloxacin in the timeout group. So maybe it worked well for getting people on oral faster. All our clinical outcomes are unchanged. So do timeouts work? I don't know. What's the best way to do them? I'm not sure. We found that, people liked it. The pharmacists felt empowered. The residents and the attendings liked having the discussion. Did it make a huge difference? I don't know. Maybe we were underpowered. I think if we'd looked maybe at time to de-escalation, we might have found a better outcome, but we looked at days of therapy. So they make sense. What's the impact? I'm not sure. We have developed the timeout sheet for on our ASAP website. So this is sort of like a timeout. This is a daily antibiotic review checklist, sort of like a timeout, somewhere in between. One of the things that we were talking about at my table today was documenting the good work that you guys do. So you guys do a ton of great work and review a ton of patients and call physicians, but it's helpful to document that. And to say, I called the doc and said we should switch to oral, and he said yes. Okay, boom, IV to PO. If I hadn't called, maybe we wouldn't switch till he left 3 days later. Okay, that's just not money saving, but that actually gets a patient out of the hospital faster usually. And so using tools like this, I think, are very important for doing our stewardship work. All right, I want to move on and talk about syndromic stewardship. Dr. Srinivasan already talked about this, that what we talk about in stewardship, we talk about decreasing resistance, that's important, but we've really changed a little bit of the message, where stewardship has really become about patient safety, patient quality of care, and efficiency of care, right? And I don't know what to call this thingy over here, but it's like the thing that defines us, right? Like culture and growth and value, and that's, I don't know what you call that. Something branding stuff. But what I point out is right in the center is the patient and patient safety. And everything we do with stewardship is usually focused on improving the safe and effective care of our patients. And so when you talk about stewardship, that's the language I would encourage you guys to use. And the CDC has shifted, and they talk a lot about improving patient outcomes. That's what we want to focus on. And so that's where I want to talk about syndromic stewardship. This is stewardship focused on infectious syndromes, UTI, pneumonia, asymptomatic bacteria. The advantage of syndromic stewardship is you're not like, well, I'm just going to talk about empiric antibiotics. This is like looking at the whole picture of how do we treat UTIs? How do we diagnose UTIs? How do we treat UTIs? How do we prevent UTIs? And so you can bundle all that, right? And everybody loves bundles these days. Bundles are the way we do everything. But the reason this is great is because it allows us to address a whole bunch of areas where I think antimicrobial decision making can go wrong. Like the first one, is it an infection? This is like the key decision point. If you think it's an infection and it isn't, you're not going to do right things with the antibiotics. Or if you don't think it's an infection and it is, you're probably not going to treat it right. So you can help people in syndromic stewardship by telling them what are the key things they need to look for to define an infection. If it is an infection, what kind of infection is it? Is it acute cystitis? Is it complicated cystitis? Is it pyelonephritis? Then how do I evaluate that? We waste a ton of money and time doing labs and imaging that's totally unnecessary. How do I choose empiric therapy? How do I adjust my therapy? How long do I do therapy? And then are there some things I could have done to prevent it? So the advantage of syndromic is usually you're going to do it multidisciplinary, right? So we did syndromic intervention on acute exacerbation of chronic bronchitis. And we did it with our pulmonologist because, boy, you know, if the pulmonologists don't agree with what I say, they're probably just not going to, and they're going to tell people to do something different. And so then the advantage was when we went to the pulmonologist to talk about our new guidance, I didn't even talk. The pulmonologist who's part of our team told his colleagues, hey, here's how we think we should manage exacerbations of COPD at our institution. Can help us improve our diagnostic activities. This is a study I love. This was done at a VA that looked at 500 infections, and they looked to see if they had the right diagnosis. And they looked just at the data right around the time the person got admitted, and they found that people had the right diagnosis about 3/5 of the time, 291 out of 500. And if you had the right diagnosis, you picked the right antibiotic, the most appropriate antibiotic, 62% of the time. If you had the wrong diagnosis, which happened frequently right here, you chose the right antibiotic 4% of the time. So wrong diagnosis equals wrong antibiotic. It's pretty simple. That's why diagnostic things are so important. This is an example of a syndromic stewardship intervention. This was done at Denver Health. They looked at skin soft tissue infection. They found that 97% were caused by staph and strep, but that 60 to 80% of people were getting gram-negative anti-anaerobic therapy and 3 or more drugs and treated for 10 to 15 days, okay? And so they did a multidisciplinary guideline. They did a bunch of things looking at lab utilization, empiric therapy, using Vanco mostly. They put in order sets, had peer champions, did audit and feedback, did a whole bunch of stuff. And by doing that, they were able to decrease gram-negative therapy, anti-pseudomonal therapy, anti-anaerobic therapy, and shift that duration of therapy significantly shorter. And in doing that, even though they used less antibiotics, they didn't have a bunch of people die. People did well. So that's an example of a syndromic intervention. You pick not only empiric therapy, but diagnosis, duration, you do the whole thing. We have a whole bunch of these syndromic things on our website. You're welcome to use them. IV to PO, I want to talk briefly about some pharmacy things. There's a bunch of drugs that have excellent oral bioavailability, and if somebody's taking a diet and taking oral drugs and they're not on pressors and ICU, they really should be on the oral forms of these drugs. The benefits, it's cheaper, shorter stays, you don't have to have lines, the patients like it better. This is a pharmacist-initiated study where the pharmacist initiated IV to PO switch, where they got the people on off of IV fluoroquinolones 3.5 days faster and got them out of the hospital 3.5 days faster. So, which all of our hospital administrators would appreciate. Lots of ways to do this, whether it's by policy. I'm a big believer in policy, that the pharmacist can frankly do this. I mean, I think a pharmacist can assess, is a patient taking oral medicines, taking a diet, and clinically stable? If they can, they should be able to switch the drug to an oral. You don't have to call the physician. That's how our policy works. This is a study that looked at pharmacists doing pharmacokinetics, vanc and aminoglycosides. And by just giving recommendations and helping with dosing, they decreased renal impairment and hearing loss. And oh, by the way, that decreased mortality. So all that pharmacokinetics decreases patient mortality. So again, another simple stewardship intervention that significantly benefits patients. Antibiotic allergy assessments. So antibiotic allergies are present in 13 to 50% of our patients. I don't know if you know, but antibiotic allergies are actually really bad for patients because they're going to get the wrong drugs usually. In clinical care, 50% decrease in getting effective surgical prophylaxis. People with antibiotic allergies have increased length of stay, increased ICU admission, more antibiotic use, more mortality, and oh, by the way, their drugs are more expensive, both in the hospital and on discharge. But we all know that a lot of those antibiotic allergies are not accurate. In this study, they implemented a penicillin allergy skin testing protocol, and they found 1 out of 146 people who said they were allergic to penicillin actually were. And by doing that, they saved an estimated $82,000. And so there's lots of ways to work around antibiotic allergies, whether you're using desensitization or graded challenge or just doing education or improved documentation. But But even just sorting out patient allergies can improve patient outcomes. This is a guidance document we put together with some of our allergists that basically said, listen, you know, if you previously tolerated beta-lactam, go for it. If you haven't, if it's been more than 10 years, even if you had hives and urticaria, you could try a graded challenge, which is like a short version of a desensitization. You guys are welcome to review that. Antibiograms, so I think we talked a little bit about antibiograms. I just want to give an example of how we used an antibiogram. So back before we used lots of vancomycin, we used vancomycin and ciprofloxacin, right? If 2 is good, 3 is better. And so we said, boy, if you're resistant to piptazo, you're probably going to be resistant to fluoroquinolone too. And so we developed what's called a combination antibiogram, where we looked and we said, if you're resistant to piptazo or ceptin, what are you susceptible to? Well, it's not fluoroquinolones. And so if you're adding a fluoroquinolone, you're really not adding much. And we said, well, what is active? Well, tobramycin. Said, listen, most people, if they're really sick, vanc, and here is our lovely Zosyn, or cefepime, and then if you really think you need to add something, you could add Tobra, because it's more likely to be active, and a short course of once daily tobramycin is pretty non-toxic, but you should really only do it in our most sick patients. And so when we did that, our IV ciprofloxacin, which is there in the blue line, dropped 50%. All we did was change our order sets, educate our ICU physicians and our ER physicians. Now our tobramycin use did go up 50%, but it went from 12 days of therapy to 17 and a half days of therapy per 1,000 patient day. And so I will gladly trade 50 days of Cipro for 5 days of tobramycin. So an example of how you can use both an antibiogram and guideline. This is something we have on our ASAP website. This is like education about antibiogram. This is an example antibiogram that says, hey, these are highly active oral antibiotics you should think about using if you're treating for, particularly E. coli. Oh, by the way, if you notice, levofloxacin is only 60% active. You probably shouldn't use that if you're treating a UTI. And so that's a way you can take even just a few bugs and a little bit of data and really take that data and just give some very specific education to your clinicians about how to use that data. Rapid identification, Dr. Diekema talked about this. There's a whole bunch of new technology that's coming. It's beneficial to patients. He already mentioned this. This is a study that looked at Staph aureus and coagulase negative staph, sorting that out. By sorting that out, you're able to get people who had MSSA or MRSA under the right drug faster, and people who had coagulase negative staph off of antibiotics faster. This is how we've tried to tie our rapid diagnostics in with our antibiogram. And so we said, listen, if you have like group A strep, you don't need Vanco, you don't need Zosyn, you can do penicillin. That's great for group A strep. Now, if you have a gram-negative, because it's a little harder to know, this is where the antibiogram is useful. And they say if you have Proteus, 97 to 100% of our Proteus are susceptible to ceftriaxone. You could just go ahead and use that. We don't need meropenem and tobramycin. But if you have, say, Enterobacter cloacae, boy, ertapenem is even like 20% resistant. And so maybe that's not a great choice. Maybe you want to go with meropenem. And so we tried to really pair that data. We talked a little bit about this. Dr. Cernich asked that great question about antibiograms. This is how we've tried to put that in people's faces. I'd love to have that data pop up with the culture, but that's a little beyond what we can do with clinical decisions. I'm not going to mention this, that same meta-analysis Dr. Diekema mentioned. Procalcitonin to finish up. So procalcitonin is a biomarker. It's the most specific biomarker we have for bacterial infection. It correlates nicely with severity of illness. It rises rapidly. It has a nice decline with treated infection. It's not generally impaired by immune suppression, although there are some things that can impair it. There have been numerous randomized controlled trials looking at it. This was published just this year. Meta-analysis, so patient-level meta-analysis means they got the data for all 6,700 patients individually and analyzed it individually. And what they found is that it decreased antibiotic duration in respiratory tract infections about 2.5 days. And oh, by the way, procalcitonin management decreased antibiotic-related side effects and actually decreased mortality. And I think the reason it does that, I'll just tell you my opinion on this. We don't know exactly. Why does a biomarker help us? I think it helps us, one, because antibiotics are toxic and have bad side effects. And if we can get people off of them, let's do it safely off of them. And two, it helps us identify people where something funny is going on that we didn't necessarily know. Ooh, the procal's high, but something funny, I don't think they need antibiotics, but so why is it 4? I need to look a little deeper here. It's my thought, I don't know. This is the data on sepsis, another meta-analysis of critical care medicine that was e-published at the end of this last year. Decreased antibiotics in sepsis about a day and a half. In sepsis, it's more useful for early discontinuation rather than deciding should I start or stop. And this is the data on mortality. Didn't decrease mortality, although getting close. Less data in sepsis than there is in respiratory tract infections. All right, good, we made it. So, key things. Use your team, use your data to develop your plan. When you implement your plan, monitor its effectiveness, and then choose from those strategies. I didn't hit every strategy. There's a bunch more out there. Customize it to your facility. What works? Think about what happens at your facility, why people do what they do, how can I tweak that, what beliefs are driving that, talk to the people who are doing the prescribing. Again, I think that's why it's so important to have physicians engaged in the process, because it's their thinking, a lot of times it's driving this, and that thinking may not be correct. People talk about, what's it called, strongly held misbeliefs are actually the hardest thing to change. And there are a lot of strongly held misbeliefs about infections and antibiotics out there. So one thing I'd mention for ASAP, if you'd like, you can sign up. Phil Chung has a blog he does regularly. We do a bunch of updates. We're moving to sort of a video-based stewardship coaching model where we'd like to be part of people's teams and help them out. If you're interested in that, you can certainly contact us. And with that, I will stop and take questions.